To AIOS for giving me a chance here. Good evening, everyone. My topic for today is a small flap saving technique for recent DCR, repeat DCR, and the author has no financial disclosure to mention. And as published in various journals, success rate of external DCR is 85 to 98% now. And in spite of excellent success rate, there are a large number of cases with failure, typically due to all these poor surgical technique, intranasal adhesion, fibrous obstruction, closure of osteotomy, and fall of the mucosal flap. And the impact on the surgeon, who is always the second victim, is significant now. And the effect may be physiological, physical, emotional, or behavioral. And the personal communication with many ophthalmologists reveal that the failure of the procedure and tedious flap making in DCR are the main cause of reluctance from this surgery. And as a result, DCR is ignored by many eye surgeons, and lacrimal surgery is increasingly being undertaken by ENT surgeons now. And we are losing our domain by ignoring this. That's why, to overcome the problem, I conceptualize this method to repeat surgery, which is easy to perform with successful results and short learning curve. And changes I made were use of Aruga's bone trephine, this one. Approximately 1 mm to 2 mm of lacrimal sac was shaved around the common internal opening and sutured with subcutaneous tissue or periosteum of the medial side, because it is always difficult to get sufficient flap for mucosal anastomosis in repeat surgeries. Hence, the technically difficult flap making and suturing posterior flaps are omitted in this modified procedure. And the 1 ml of 0.4 milligram per ml mitomycin, C syringing in newly formed passage on 5th post-operative day. And the aim of my study was to assess the success rate of repeat DCR by my technique, a small flap saving technique. And it is a prospective, uncontrolled, and interventional studies. It is in the 134 patients were included from March 2011 to 2021. And all the surgery was done by single surgeon. And the inclusion criteria were persistence of EP4A with regurgitation of pus or TN or pressing lacrimal sac area after at least 6 months of the primary procedure. And the incision were made on the previous surgical scar, and intervening fibrous tissue was excised. Roughly 1 to 2 mm of the lacrimal sac around common canaliculi was shaved, so that the sac remained as a disc with punctum in its middle, similar to a funnel. And here A is the sac remain and B is the common canaliculi opening. That is tip of the moment probe coming out of the common canaliculi opening. And here is the procedure. Ostium of the nasal bone and nasal mucosa was made using 10 mm Aruga's bone trephine. And remaining anterior part of the sac was sutured with subcutaneous tissue or a periosteum of the medial side. A skin was opposed and sutured. And this is the final on the 5th post-operative day. Syringing of 1 ml of 0.4 milligram per ml of mitomycin C in newly formed passage. These all cases were followed up for 1 year. And this is the nasal endoscopy after 1 year. And this is the opening. And these all cases were followed up on 5th day, 1 month, 3 months, 6 months, and 1 year post-operatively. And at each visit, the surgical outcome was assessed anatomically and functionally based on records from the last visit. And our anatomical success was defined as patency of the newly formed passage on syringing. And the functional success was defined as tearing assessment using Monk scope. And EP4A of grade 0 or 1 was considered as a success. And the result of 134 patients operated over 10 years and 131 patients were successful at the end of mean follow-up period, that is 12 months, that is 97.7%. 2% patient complained of EP4A of grade 2 or more, and sticky eye despite successful syringing and patent newly formed passage, and 1 patient failed in syringing. And now we come to the statistical analysis. For comparison of this study with previously published studies, a meta-analysis were performed using MedCalc software and descriptive statistics were obtained to determine the frequency and a proportion, and mean and a standard deviation was calculated for continuous variables. And the Cochrane chi-square test and inconsistency were used to assess the heterogeneity among a study, and p-value less than 0.05 was considered to indicate the presence of heterogeneity, while inconsistency less than 50% was considered to indicate acceptable heterogeneity. And this is the comparison of success rate with published data as yet. And this is the meta-analysis of success rate reported in identified studies on failed DCR, and a random effect model was used to incorporate heterogeneity in meta-analysis, and this model showed our model highest success rate reported by us, and the presented study weight all included studies had almost equal contribution towards all overall summary result in this meta-analysis. And this is forest plot depict the study by it all can be a source of heterogeneity, and the symmetrical plot suggests absence of bias, and the meta-analysis of the success rate shows significant heterogeneity, that is 87.48%, and the p-value less than 0.001, that is heavily reported in this study. And now we come to why we use 0.4 milligram per ml mitomycin C, because safest and most effective dose of mitomycin C is somewhere between 0.2 milligram to 0.4 milligram. And why mitomycin C syringing on 5th day? We used 1 ml of 0.4 milligram mitomycin syringing on 5th postoperative day, so that the antifibrotic property of mitomycin is utilized maximally, as it is not diluted by bleeding from nasal mucosa, and better coincides to early proliferative phase of wound healing, which starts from 4 to 5 days of tissue injury. And here is our anatomical success is 99.2%, and functional success is 97.7%. And the success rate of this study is significantly better than the previously published report, despite large sample size. Yeah, I can say this, our method is not for them, but it is boon for the masses, which constitutes mass of the India. Thank you.
Thank you, Dr. Ranjan. It was a nice study. So did you publish it also? You have published the study?
I have planning to send it, sir.
All right, because your data analysis and everything is according to a published.
By my
okay. So it's a nice thing actually. Only point of concern is that how could you suture 1 to 2 millimeter of flap? It's very difficult to pass suture needle through that and to hitch it to the periosteum.
Actually, I am suturing
the common canalicus opening is also right there. So it's
I have only anterior part I am suturing. Posterior is just free.
Sir, are you doing both endoscopic and conventional DCR?
No.
नहीं, I'm asking sir, आपसे पूछ डॉक्टर मुकेश सर, आप दोनों करते हो, एंडोस्कोपिक भी करते हो और वो
नहीं करते हैं.
I do endoscopic examination, but I do not do
because I also don't do endoscopic, but for me I still feel that the gold standard is still conventional DCR.
मैडम फेलियर रेट इज़ दैट मच हाई कि पेशेंट आता है कहता है कि आप इतना पैसा भी ले लिया, कुछ फ़ायदा भी नहीं हुआ 6 महीने के बाद.
बिकॉज मैं समझी नहीं सर आप क्या कह रहे हो.
पेशेंट आता है दोबारा इंडोस्कोपी के बाद, कहता है कि आप पैसा भी ले लिए, फेलियर रेट 6 मंथ्स के बाद बहुत ज़्यादा है इंडोस्कोपी का, तो वो झेलना बड़ा मुश्किल हो जाता है.
नहीं ज़्यादा नहीं, बट एटलीस्ट मेरे कॉलेज में भी ज़्यादा है. Because we get lot of, I am not doing, our ENT department is doing few of them, but हमारे पास failed बहुत आते हैं. Yeah, maybe.
Correct.
Yeah, that's true.
My view is.
That's why I'm asking. Learning curve.
नहीं, my view is cosmetically it may be vapor endoscopic surgery, but as a result.
तो conventional will be better, definitely. हाँ. Yeah. Yes. That
Madam,
also, and
in my view, doctor is more beneficial than patient in case of endoscopic DCR.
Fistula cases you have to do conventional. I don't think fistula.
All right. So.
Okay. He must be. I am not going again because I have no experience of endoscopic. हमारे यहाँ पे failure rate ज़्यादा है. Vandana, you wanted to add something?
Correct. I think we invite Dr. Shikha for